this afternoon. So you are all welcome, and I wish us all a very fruitful discussion. Ariel, please.
Thank you very much, Alon. Good evening, good morning, good afternoon, everybody. Thank you very much for joining us today for a discussion on the global equitable access to COVID-19 vaccines with focus on the global south. My name is Ariel Blumi, and I'm the chairperson of SEED Israel, the Society for International Development, and I'm honored to facilitate this discussion today. It is no secret that COVID-19 pandemic has faced the world with a new global challenge. The pandemic exposed, surfaced, and also exacerbated already existing gaps and disparities between countries, regions, and communities. We have today 4 excellent speakers joining us from Kenya, Nepal, Israel, and the United States, and they will help us to shed some lights on the situation of the pandemic in the global south and the status of the vaccine rollout globally. Throughout the discussion, our chat will be open. You're welcome to post your questions. Please try to keep the questions short and, if possible, in a WH form. Our opening speaker today is Dr. Oren Levin. He insists that I call him Oren. Oren is the Director of Global Delivery and Global Development at the Bill and Melinda Gates Foundation and a board member of the Global Alliance for Vaccines and Immunization, aka Gavi. Dr. Levin, thank you very much for joining us today. And without further ado, the floor is yours.
Thank you, Ariel. It's my pleasure to be with you all today. Morning time here in my basement in Seattle. I know afternoon and evening where many of you are, but really a pleasure to be with you and to have a chance to have this conversation with you. I am very fortunate that I work at the Bill and Melinda Gates Foundation, and one of the opportunities that I have here at the foundation is to represent the foundation on the board of Gavi, which is, as many of you know, a part of COVAX, this international collaborative effort to help accelerate equitable rollout of COVID-19 vaccines. And so that's brought me very close to an issue that's very important, I think, to me and to all of us at the foundation, which is how do we try and strive for greater equity in the access to and delivery of COVID-19 vaccines. So what I thought I would try and do today is maybe do a couple of different things. First, kind of summarize the current status of where we are on that ambition of equitable rollout. Next, maybe talk a little bit about the kind of trajectory that we see for COVID vaccine rollout, with an emphasis on some of the different stages of vaccine rollout and the bottlenecks that we see emerging. And then wrap up a little bit with where I think there's opportunities for quite a lot more to be done, and maybe even opportunities for those of you participating today on this conversation to lean in. So here a couple of things that we just got to get out of the way, right? First of all, amazing heroic effort undertaken to develop COVID-19 vaccines, right? Less than a year from when we first sequenced this virus to having a licensed vaccine available. That is a timeline that has never, ever been met before. And it's an incredible testimony to all of the academics, governments, private sector, everybody involved to be able to make that happen. It's also true that early December is the last time we had equitable vaccine rollout because we had everyone on the planet not getting vaccine. As soon as we started to use vaccine is when we started the clock on how equitable our rollout would be. And the inconvenient truth today is that we are not experiencing an equitable allocation of doses. We're not experiencing an equitable rollout. There's various figures that you can find in the news, but about 75% of all doses manufactured to date have been used in 10 countries. We're on a pace where we are going to be vaccinating, or we are vaccinating 16-year-olds in America who sit at home and go to Zoom school before we vaccinate healthcare workers in Africa and South Asia, for example. And that's not inherently equitable. I think all of us would agree that when one part of the world is at 80% coverage and one part of the world is going to be only at 5 and 10% coverage, that's not the equity that we aimed for. It's not what we had as an ambition. And there's a lot that can be said about why it is the way it is. I'll focus on a couple of pieces, but I prefer to be more forward-looking and problem-solving than backward-looking and dissecting. Here are a couple of the characteristics that I think are addressing us right now. COVAX is, for all intents and purposes, the single global entity working to try and address vaccine rollout through equity as the central principle. All the doses that come into COVAX are allocated according to an algorithm to make sure that all sort of countries rise up in their coverage at an equitable rate, not as a kind of function of political gain or financial gain or any of those other types of things. Now, I firmly believe that we are in a better place because we have COVAX than we would have been without a COVAX. And at the same time, I believe that we have a lot more to do with COVAX. So why hasn't COVAX delivered the equitable rollout that we want? Well, first of all, the vast majority of doses were secured by high-income countries through deals in advance of the vaccines being licensed, right? So countries like the US put billions of dollars down on the table to advance their manufacturing and to secure doses at risk, even before they were manufactured, which has given them the ability to kind of consume those doses ahead of time. The other reality is that the big bolus of doses that we expected to be able to roll out with first through COVAX were going to come from the Serum Institute of India. It would never have been the volume that we see from U.S. consumption right now, but it had been substantially more than what we're seeing today. That's not transpired the way that we had hoped. The manufacturing productivity has been lower than what we forecasted for this point in time. And the consumption domestically in India, in the face of a massive pandemic surge, has been higher than expected. And those two pieces together have meant that all of the Indian manufactured doses have largely been consumed in India. Greater manufacturing from India gives us a chance for doses to leave India, and then obviously controlling the pandemic in India helps as well. So there's this challenge going on right now with the early vaccine doses that were secured by deals with COVAX. All that said, COVAX has shipped over 40 million doses to over 100 countries, so that's a start. But it's a small start. 40 million doses is what the U.S. consumes in 2 weeks. And spread over 100 countries and over a 2-month period, it's just not the same volumes. So when can it get better? I think we're going to start to see it getting a little bit better as dose donations start to materialize. So there are a number of high-income countries that are oversubscribed, if you will, in number of doses. If you look at the ratio of doses that they've secured in deals to the number of inhabitants that they have, that can go as high as 7 or 8 doses. I think Canada has something like 7 to 8 doses secured per Canadian. And if you look at a place like the U.S., we have contracts for vaccines like AstraZeneca that we have not even started to use, and yet we are in a supply in excess of demand situation in large parts of our country right now. So as this begins to evolve, I think it creates the opportunity for countries like the US and other high-income countries that are oversubscribed to be more generous with giving away doses. And you're beginning to see that, right? France has recently made a commitment to donate to COVAX a bunch of doses. I think I saw today that there's a shipment going to Mauritius, born out of the French commitment. New Zealand has done the same. America announced yesterday that the AZ stockpile of doses that have been developed but not yet regulatory approved, once they get regulatory approval, will be made available for donation. So we're starting to have that happen. That's one source of volume of doses that I think can change the supply dynamic for a lot of countries. The other is the contracting that COVAX has done is with a broader set of manufacturers now. And I think it's possible that between September and December, if everything goes well, and remember, like, not everything's gone exactly the way that we wanted it on vaccine supply, but if everything goes well, it's plausible that 1 billion doses could be shipping to low and low middle income countries in the final 4 months of the year this year. That will be a big increase in supply and create a different dynamic for vaccine rollout. So let me shift a little bit into what we see coming. And some of this may resonate with those of you living in Israel, because I think in many ways we are learning for the developing world from the success that Israel had in its early rollout, very successful introduction and rollout of the vaccine, and then with some of the other countries that are in early phases of introducing and using COVID vaccines. We're trying to learn from them as well. So the first thing I would say is we're expecting vaccine rollout to kind of go through 3 stages. The first stage we'd call introduction, and it's a stage where typically demand exceeds supply. Supply is erratic. People behave conservatively. I'm not going to do too much to generate demand because I'm not yet trusting that next shipment of supply is going to come in. This is where a lot of developing countries are right now. They're in that, like, I got a few doses, but I don't know when my next doses are going to be. I don't want to create too much demand and upset things. I want to use the doses I have. It doesn't overwhelm your system. You can typically manage it through the existing channels that you have. But then there's a period where supply gets secured, and there's a bump in that curve with supply that then takes us to a ramp-up stage, a second stage, a ramp-up stage, where high throughput matters a lot. You're going to be ginning up demand as supply is coming, and getting that supply-demand balance right becomes a big part of the total effort. And it helps you to minimize inventory and really maximize the number of doses becoming vaccinated people. That's a operational complexity that's a slightly different level from the level that we're talking about. And just to put that into context, the biggest injectable vaccine campaign effort that I am aware of globally was India's effort to vaccinate everybody 9 months to 14 years of age with measles rubella vaccine. It was 400 million people over 2 years with 1 year of advanced planning and a single shot. None of those are the situation that we're going to likely have with COVID vaccines. Most of our vaccines are going to be 2 doses, 1 billion doses in 4 months, and maybe 6 months of planning to try and kind of get ready for that. So what we're undertaking in terms of the ramp up phase will be as heroic as what it took to develop the vaccines in the first place in order to do that. And the third stage is a stage where supply begins to outstrip demand, and the focus is on tailoring demand to communities that either were left out and left behind because there weren't intentional efforts to put equity in the rollout plans, or where vaccine hesitancy has emerged. But it'll be an attention to those communities, a kind of specialized effort to reach those communities that will I think be the flavor of that third stage. And just to be clear, demand is an issue throughout all three stages, but the relative emphasis on demand changes in different ways. So if we imagine a kind of S-curve of vaccine rollout in countries that goes through those three stages of introduction, ramp up, and then tailored demand, what are some of the bottlenecks that we're experiencing or seeing? Well, obviously supply is one. We've talked about that. But funding for the delivery costs associated with this are also a gap for many low and low-income countries, and are not being met by COVAX the way that funding for procurement of the doses is being met through COVAX. They're much more reliant on either domestic resource or multilateral development banks like the World Bank, African Development Bank, Asian Development Bank. Increasing concerns about vaccine hesitancy. One of the things that's emerged already in some of the early rollout in places in Africa, and I'm certain it's a feature in other places as well, and maybe some of my colleagues like Dr. Adhikari today might speak to whether this is a factor in her community, but we're seeing healthcare workers being hesitant to be vaccinated. And so they're at the front of the line. There's a kind of almost universal value of reciprocity, I think, that has led every country in the world to put healthcare workers at the front of the line for who gets vaccinated in the early stages of their vaccine introduction. And so the fact that healthcare workers who benefit from the protection of vaccines because they care for people who are COVID infected, their hesitancy can have a significant dampening effect on later stages and put at risk the very people that we count on for healthcare service delivery. So vaccine hesitancy, I think, is going to be a significant issue. Healthcare worker vaccine hesitancy is one that's already emerging as a bottleneck and a concern for many countries. The challenge of getting vaccine supply right now has so locked countries into kind of that first stage, that introduction stage where demand is so much in excess of supply, that it's sometimes been hard to get them to kind of suspend disbelief and plan for a moment when a high throughput may be really, really critical, and to start planning for that operational complexity of when you'll need a greater volume of doses. And when you'll be getting a greater volume of doses, then need the kind of operational complexity and forward planning to be able to absorb those and use those quickly and effectively. So there's quite a lot to do in terms of building out the forward planning for a better moment when a larger volume of doses comes through. And I think one of the other things that we've seen in looking at the vaccine rollout plans that have been made is there's not always an intentional effort at a domestic level to focus on equity. I know in the US that has been a major feature of our vaccine rollout, that people with privilege have definitely benefited earlier than less privileged communities in America for a host of reasons. But one of the things that we're seeing here is where people are more intentional about building an equity focus into the plan from the beginning, you are more likely to experience a more equitable rollout. So that's a really important one. So maybe just to wrap up, because I really want to get to the discussion, hear from the other panelists and hear from all of you with your questions, maybe just a couple of thoughts about kind of what's left to be done. There's always an issue of funding. I can't ignore that. There's shortfalls of funding for both procurement of doses and delivery of doses. And national governments have stepped up around the world to help make those funds available, but we're going to have to keep doing it. We're not safe until everyone is safe, and we're not protected until everyone's protected, and that's going to take a sustained emphasis on the funding part. Dose donations, I think, are one of the single most important opportunities in the second half of this year. As I just think about the complex of contracted doses and manufactured doses, of where the money is and all that kind of stuff, one of the biggest ways that we can supplement what COVAX has secured through deals is to get some of the unnecessary doses. And we did a simple analysis for our team. If every one of the oversubscribed high-income countries, basically the G7 and a few other countries, even if they vaccinate 80% of over 12-year-olds with 3 doses this year, there would still be 1 billion doses left over that they could donate. So we're not asking them to cut it right to the edge, right? There's a significant surplus there that can be reallocated. There's a lot more that can be done with technical assistance and planning. As I mentioned, you can imagine, many health systems are overwhelmed by the response to COVID in the first place. Just the provision of PPEs, diagnostics, oxygen, any of those kinds of things is taking a whole bunch of their energy right now, and then they're scrambling to get their hands on small volumes of doses. So amidst all of that, asking them to put their head 4 or 6 months in the future and plan for a high throughput on a volume of doses that they may have never had the experience of doing is just hard for them to kind of rationalize the effort and energy, or to even get their mind into that place. Not that they aren't doing it, but in that hierarchy of things, it's often falling to the bottom. And we don't have a lot of time to do that planning. So assistance with planning and an emphasis on building plans that enable high throughput when the supply situation occurs, and focus on equitable rollout from the beginning are really, really, really key. I think there's also a lot more that we need to do in understanding how we address the concerns of vaccine hesitant communities. It's a problem that's emerged everywhere. Let's face it, the internet doesn't help us with a lot of that. It can actually be a significant contributor to spreading false ideas, as much as it can be a contributor to sharing the factual ones. So there's a lot more that needs to be done there, and I have no great answers for that. That is just a really, really tough problem, but we could certainly use a lot of help with trying to address that. So maybe with that, I'll just kind of wrap up there, and look forward to hearing the discussion from the rest of the panelists and the questions from all of you. Thank you.
Thank you so much, Dr. Levin. And I think despite all the challenges that you have described, you have left us a little bit more optimistic with the idea of countries that are oversubscribed and maybe can pass over some of the vaccines to less fortunate countries. We are now moving to our panel members. We have wonderful panel members from 3 different countries. Our first speaker will be Dr. Puspanjali Adhikari. Dr. Adhikari is a project coordinator of rheumatic hair disease research and screening in Nepal as well as interdisciplinary research project on improving respiratory health from the Department of Community Program at Dulikhel Hospital at Kathmandu University Hospital. Dr. Dulikhel, I would like, Dr. Adhikari, I would like to ask you to share with us the situation of COVID-19 pandemic in your country and region, as well as the situation of the vaccinations. And if you could also talk a little bit about the constraints, whether we are facing technical constraints such as funding or access, or maybe more adaptive challenges such as perceptions, fear, etc. So, Dr. Adhikari, the floor is yours, please.
Thank you so much, Ariel. Yeah. So currently, if we talk about Nepal, we are experiencing more surge in case than the ones that we had in the previous years. Like the positivity rate is more than it was in the previous years. So we have around 26,225 active cases with the mortality rate of 1.1% till date. So in the last wave, we were till now, we have around 3 million people who are already affected by COVID. And so there was we started experiencing the first peak of the COVID-19 at around October or December, and then October and December last year, and then so slowly it was, by the time it was January and February, we were not experiencing much cases. But then as we are a landlocked country with India, as India started experiencing the surges in cases, we are also experiencing a surge in cases, and this time it is the infectivity rate is more, and then there are more severe cases. So that is the current situation of the COVID-19, and we are like there are daily reported cases of around thousands or 500 to 1,000 daily reported cases, and 20 to 25 deaths. So that's the situation with the COVID-19, and we are in a at the setting of experiencing another wave in maybe next month, maybe around the end of May or June. So that is the current situation. And if we talk about the vaccine, so we actually started. Our country had started the rolling out the vaccination program we started at the third week of January, and then we start giving vaccine in a phase-wise fashion. So we are a country where we have community transmission, and the vaccine is not enough. So we like Orin had said earlier, we are in the stage 1, so where the demand is higher than the supply. And so we've been able to vaccinate around 7% of our population till date, and of course we have received despite the fact that COVAX facility has mentioned that 20% of the population would be vaccinated by the end of May 2021, but then the scenario is not such. We received earlier when we rolled out the first vaccination session, of course abiding by the principle, by the framework, the WHO says framework of equitable distribution and reciprocity. We started with vaccinating the frontline workers first, and then we moved to the the elderly population, and then we moved to the people who are more exposed to the general population. So we started that. We did it in the phase-wise fashion. So earlier, when we rolled out the vaccine in January, we had received around zero point 0.3 million of the vaccine from the COVAX facility. Then it was the Serum Institute of India that donated us with 1 million. And later on, around April, February, around April, we actually we actually brought 22 million vaccines from the Serum Institute of India, but then we've only been able to receive 1 million from them, and then because of the surge of the cases in India, and also because they've been not able to fulfill the demand in their own country, they've not been able to procure the other 1 million vaccines. And in Nepal, we have vaccinated. There are around 7% of people who are around 2 million people who are. We are a population of 28 million, and then there are 2 million people who are already vaccinated with at least one dose of vaccine. So, and that one dose of vaccine include Covishield, the AstraZeneca, and also the Sinopharm, the Sinopharm, which was donated by China to us, around 0.8 million vaccine. Now, if we talk about what are the constraints of rolling out this vaccination program, of course, there are this. The funding is a bigger constraint for us, and also I think the other bigger constraint for us is also the collateral partnership and communications with the with other donors or partnering countries. So that is also one of the constraints. And I think like Orin had raised a concern that there were the frontline workers who were actually hesitant to take the vaccinations when we rolled it out in the first phase. And that was because people were really apprehensive about the efficacy of the drug. They were, they were not. They were not informed well about. Maybe they were not more information for them about the vaccine, about the AEFIs related to the vaccine, and people were more concerned. The frontline specialists were more concerned about the AEFIs, and also we were also concerned about. We had not received. Another lot of vaccine. There were only limited vaccines, so people were concerned whether they would be able to receive the second dose of AstraZeneca or not. So that is why there were a lot of hesitancy among the people. But as we started getting vaccines, there are people, and then as more and more people started getting vaccinations, and there were less AEFIs associated with vaccine, people started becoming more confident toward receiving the vaccines, and that's why we've been able to actually vaccinate around 2 million of the population with at least one dose of the vaccine.
Thank you so much, Dr. Adhikari. We will get back to you very soon. Our next panel member is Professor Zvi Bentwich. Zvi is a physician and immunologist. He serves as the head of the Center for Emerging Tropical Disease and AIDS at the Ben-Gurion University. He also serves as the president and founder of the Nala Foundation. Professor Bentwich, I wanted to ask you about the collateral effects of COVID-19 on the health situation in low-income countries. How other health challenges such as malaria, TB, HIV are affected by the pandemic. And maybe I will also add here a question that we just received from the ambassador of Vietnam in Israel about the patents, how much they are preventing equitable access to vaccines around the world. Please, Dr. Bentwich, Professor. Zvi, you are on mute. You're on mute. Just unmute yourself.
Yeah, no, so okay. So thank you very much for the introduction. And I want to start, before I answer your specific questions, I want to start by commenting or responding to the major issues that are raised by this total story or topic of COVID vaccination. I think one thing is missing in my mind in the general policy, and that also applies to the very relevant and a very good introduction by Dr. Levin. And that is that since COVID is a disease that affects primarily and most importantly elderly and higher and advanced age population, and it does not, and again, I'm generalizing, maybe making it too simple, but does not affect most of the population, and more importantly, not children. I am surprised in a way, and then I'm raising this as a challenge, that the selection of population to be vaccinated not come up really, and this is in the face of such shortage of vaccination. So in other words, I hear that the different countries are trying to do, and what has been done, in a way, fortunately in Israel, that has been able to vaccinate 60% of its population. If in a good world where such many countries don't have access to vaccines, I think the distribution, or at least the administration of vaccines definitely in low-income countries, should be first and foremost focused on the elderly and risk populations rather than the whole population. So this is one, and I would even say this is a challenge to WHO, to countries, to governments. I would like to see a convention or some discussion on a higher level that would combine administration to selected population, and B, of course, try and provide low-income countries with more vaccine. Now, coming back to your question, I would say that it is very clear that COVID does have an impact on the other chronic or the big epidemics, in the sense that they have been now neglected. I'm used to neglected tropical diseases, so that's something that we have called neglected, but this time malaria, tuberculosis, and AIDS, HIV/AIDS, have suffered significantly from this epidemic by being neglected, by being not able to get the means and the things that were in place. So this has become, I would say, a very important element in looking ahead or looking towards the future. The second thing that I think is very impressive, and that is the success of the vaccines should be looked, I think, in a somewhat different perspective when you have such a shortage. And the different perspective that I mean is that it may not be such a stupid policy to at first provide the first immunization rather than stick to immunization. So I'm not trying to doubt that 2 shots immunization is more effective. But if you have such a shortage, it would be, I think, advantageous to give even 1 shot, which certainly give some degree of protection. Lastly, you asked another question which I didn't write. What was, Ariel? Was there any other thing that you wanted me to address? Ariel?
I think Professor Bentwich, that you answered the questions, and maybe I'll add another short question for you. Is what lessons can we draw from previous pandemics, as someone who has been in this field for several decades now?
Since the topic of this webinar is vaccination, so I don't want to dwell too much on lessons, because the lessons have been, I think the lessons of previous epidemics have been regretfully not sufficiently applied when one looks at this epidemic. And what I certainly have in mind is the public the public information and I would call it education, health education, which is very, very deficient. In other words, if we take even the Israeli as an example, policy of frightening, of increasing almost hysteria, or in other words, the menace, the threat has been emphasized much too much compared to proper and direct explanations and instructions. And you know, I have been there I've been with HIV/AIDS right from its beginning, and one very important lesson that we learned there is that taking the route of fright, of threat, is a much less, not only less productive, it is counterproductive, and cannot replace proper explanation and instruction. And that applies, of course, also to the compliance, or to the readiness of populations to vaccinate, for instance. You have to explain why vaccinate. You have to overcome the fear or the anxiety and so on. So I would say that we are very, very fortunate to have an effective vaccine. This is really a game changer. There's no doubt about it. It does not replace the need, at least at this time, when large proportion of population, world population, doesn't have access to vaccination, to emphasize and to put a lot of energy in the instruction, in education, in preparing people to what they can cope with, what they can do to prevent until vaccination is effective.
Thank you very much, Professor Bentwich. Thank you very much for raising the point of the elderly population. And thank you very much also for mentioning my favorite rap singer, Eminem, If You Had One Shot. Thank you so much. We are now moving to Kenya. We are joined by Dr. Stella Busire Wairimo. Dr. Busire Wairimo is a Kenyan physician, a corporate executive, and a human rights activist and author who serves as the co-executive director of UHAI. Thank you very much for joining us today, Dr. Stella. Unfortunately, because of a bad internet connection, we will only hear your audio and will not be able to see you, but I think it's good enough. Could you please share with us the status of COVID-19 and the vaccinations in Kenya and your region, and also maybe speak about the constraints? I think that Dr. Levine mentioned them before, and also Dr. Adi Keri. What constraints that are not technical constraints are we facing, and how can we meet them? The floor is yours.
Thank you so much. Thank you so much, Ariel. Can you hear me? Can you hear me?
Very well.
Excellent. Thank you so much. Excellent conversations that we are having. So far, I don't know if I want to use the word lucky or privileged to be a country where a number of cases have been less than 200,000 with only less than 2,500 deaths so far, with a majority of the people, about 110,000, having recovered. I usually say one death is enough death to make us uncomfortable, to make us be able to ask a lot of questions. But I mean, if you look at the case fatality rates, we are not doing, our country is not so much experiencing what we are seeing in other countries, what other countries are experiencing. We procured about 1.3 million vaccines so far, the AstraZeneca Oxford vaccine under the COVAX global mechanism for procurement and distribution. So far, we have vaccinated about 750,000 people. Key among them, frontline workers, healthcare workers, there were teachers, there were elderly people above 58 years of age, and patients who had chronic illnesses were among the people who are prioritized on this phase 1. We have just consumed our phase 1 vaccines, and then we are hoping for the next shipment, which where we are right now, because of the different, I don't know if I want to call it biomedical or political warfare and criticism around the Astra Oxford vaccine, we look like we are going to get the Johnson & Johnson vaccine. So we are still in limbo about how it is that we want, what kind of vaccine. But basically the two major vaccines that have been in our systems are AstraZeneca and the Sputnik's vaccine from Russia, which were granted access to our markets. We are, in terms of the vaccine access, we are seeing more, it has actually been led from a health system perspective by the government, but we're seeing right now an introduction from private sector, where private sector also wants to be part and parcel of the vaccine rollout. But of course, this is also an issue of cost. And this is specifically speaking to the Sputnik 5 vaccine, which is from Russia. We are hopeful that we are 50 million Kenyans in this country. We are hopeful by the end of this year, we'll have vaccinated about 30% of the population. Of course, even as you're sitting here, we know that's not enough a population to be able to even accord us herd immunity. We need to have more than 80% of the population accessing vaccines. When you ask me, Ariel, what are the constraints? I will just shoot to the hip as a human rights doctor and tell you the truth, that the truth around vaccine consumption for Africa lies in the inequalities that exist in the biomedical information infrastructure and lack of a healthcare financing model that really ensures that, one, we can be able to generate our own vaccines. Of course, this is looking at the issues about patenting, and I've seen the ambassador for Vietnam has actually raised that issue. I know South Africa and India went and took some of the global North organizations to WTO asking for flexibilities around TRIPS. And until now, unfortunately, we have not seen any flexibilities that have been introduced. And that really begs the question, when you talk about inequalities, are we just talking about the issues around distribution, or do we need to start talking about right from the manufacturing, right from who holds the knowledge, who holds the information, who has the blueprint for this vaccine? And that is one of the crucial of the matter in terms of how it is that the world will be able to not necessarily normalize, because I don't think we'll ever get to a place of normalization, but adaptation around the current realities. That for us to ensure that the 7 billion plus of us who are on this planet, at least 80% of them are vaccinated, we open up access in terms of patenting. Unfortunately, the global North continues to ring fence and put structures around and stringent measures around the information, around the biomedical information around the vaccine, and that really leaves us to the masses of really WHO around the COVAX, for example, distribution and all that. When you look at country level, I mean, this is what we're witnessing in the whole world. Health system collapse. I mean, and particularly for us who, for instance, if you take a case study of Kenya has less than 300 ICU beds. And we are all aware that for critically ill patients with COVID-19, most of them who develop severe respiratory symptoms really require good respiratory and ICU care. We not only don't have ICU, we also do have challenges around the technocracy around the healthcare workers who are able to provide that kind of support. So the other thing that we are also witnessing is around the supply chain. And I'm sure even as I'm looking at the chat, I'm seeing questions around what happens in the distribution, the procurement. What about the cold chain? What is happening there? There have been challenges around that. And right now, one of the things that none of us is actually discussing so far, and I hope we'll be able to bring that out, is the anti-vaxxers, right? The people who've pushed against our polio vaccines, our measles vaccines, and who've put up narratives and lies, for lack of a better word, actually, lies would be the word, around reducing the number of people who are vaccinated in the whole world. They have infiltrated into the COVID-19 vaccine, and they're pushing messaging around, oh, COVID will bring you. In fact, they're taking our scientific message, for example, around the Astra vaccine on DVT and clotting, and literally amplifying it and quoting CDC sites. But really, if you look at this information, it's very inaccurate because it's not comparable. I mean, as scientists, we know by the time you're able to say, oh, is dangerous to the health of people. Yes, in comparison to what? We have contraceptives that have a higher risk of blood clots than we can compare with the vaccine, but we are not doing that comparison. And also what Prof had mentioned around access to health information, this is also a place where we've not done really well, because as the anti-vaxxers are actually coming out, what we are saying is that we're seeing a public in panic in the whole world, asking questions around safety of the vaccine, some of them coming out on social media and even sharing their experiences for those who've gotten the first dose. And some of them even using their experiences, and which is expected in terms of adverse effect for any kind of medical intervention, and making other people refuse to actually take this up. And that's really very problematic. I'll give you a case. For example, in Kenya, we have a very prominent doctor who's an anti-vaccine, all right from the cervical cancer vaccine all the way to measles, the under 5 immunization schedule for children under the age of 5 years. And what has happened, unfortunately, is that this doctor has actually contracted COVID and is in ICU care. So the messaging that we're asking right now, do we need to when we have technocrats like those ones who are misleading because, one, they hide around religion, because it's a Catholic doctor who hides around religion to be able to push back. What information is it that we are sharing with the public? We might sit here with a lot of information, or we can speak about the genomes and everything, and the sequencing, but what kind of information is the public taking in for it to be able to really improve on the uptick? We also have to look at how it is historically our health systems in terms of preparedness for pandemic has been a failure. I mean, this is not the first time that the world is having a pandemic, and epidemiologically, every 100 years or so we would have such a pandemic, such an outburst of a biomedical crisis. But we ask, when the mechanisms around the coordination started, one of the things that we experience is, and this is something I actually look at it from a human rights perspective, is one, the access to information. Even when some of the countries in Asia had already named this virus, before even they named the virus, but they knew that this virus really caused a lot of respiratory complications, they did not share this information. So we ask ourselves literally, even as scientists, at what particular point, or how is it that we hold such institutions or organizations or countries accountable? Because I don't think we would be where we are right now with the fatalities in millions of numbers that we are experiencing. My partner today told me that in India, 251 people have been dying every minute. I want that to sink in. Every single minute, 251 Indians have died. And that is so sad. And that is so sad, not every minute, but per hour. And that is so sad, because we have been with this virus from last year, from the first case. And it's now we're moving into the second half of the year, and we're still seeing fatalities. This is the time perhaps would be seeing cross-sharing around information, around best practices in learning among scientists, would have open sources in terms of access to research, and we are not seeing that. We are still seeing a lot of ring fencing, a lot of protection around this information. So it's really heartbreaking for us to continue counting fatalities right now, and yet, one, we have at least a 70% understanding of this virus, and number two, we are ahead of the virus in terms of the vaccine. Yes, of course, because of the issues of the variants, the C19, other variants that are coming in, we are also learning. But we need to be able to ask ourselves, in terms of when we have global pandemic, who holds the information? How is the information? How can this information be moved to each and every single person in the whole world for them to be able to respond appropriately? Thank you so much, Ariel.
Thank you so much, Dr. Stella. I can very much resonate with your position on the anti-vaccine supporters. Also, communities that I've been working with are facing lots of conspiracy theories, fake news, and so on. What I would just add is that I don't think that people are lying. I think that people that are anti-vaccine supporters truly believe that there is a problem with vaccines. And I think that we need to dig into the problems, maybe lack of trust between them and the governments, especially in minority groups, and understand how we can challenge those perceptions. And indeed, access to information is a major issue. So thank you very much for raising this point. We are now opening the floor for questions, and maybe I'll begin with you, Dr. Levine. There are two questions that were posted on the chat. One is regarding the IP that was mentioned here several times. If you can relate to this, also Bill Gates mentioned this in one of his posts. On also the issue of the cold chains, the distribution is relevant for all countries, and what can we do in cases where cold chains are not available? So please, Dr. Levine.
Yeah, thanks. Thanks for those questions. A couple of quick things. The cold chain that we've got in most low and low middle income countries is probably adequate for most of the distribution that we will do, short of a very high volume throughput scenario, and provided that we change the frequency of transportation to have more regular shipments. So you can expand cold chain and just keep stuff in at every level, or you can just have more frequent transportation. And so when we get into that high throughput environment, actually the fast use of it, the fast resupply, most scenarios, the cold chain that we have established in countries should be largely adequate. It's probably more adequate, believe it or not, at the lower levels of the system, and it's the national level where it's going to be a little bit more constrained. That's not by accident. Gavi spent $250 million in the last 5 years helping countries to install additional cold chain capacity and to upgrade the performance of cold chain equipment with newer equipment that is more resilient, more reliable under a range of different environment and power conditions. We've talked about the vaccine supply issues, and that's a major concern for us at the foundation. As I've kind of laid out, I do think that the near-term crisis of today
has a lot of people.
is going to be is going to improve a bit, not just a bit, but substantially improve in about a 5 to 6 month horizon. So our focus has been primarily on incentivizing and pushing for tech transfer, getting as many different manufacturers to be able to get scaled up to manufacture as many doses as possible. And we really see that as the major step that we can take. You're probably familiar. We early on made a big investment to help Serum Institute of India to expand their capacity and manufacture at-risk volumes of both the AZ and a different vaccine, a vaccine made by Novavax, which is a purified protein vaccine. And we're supporting other opportunities to try and kind of expand as much as possible the manufacturing base. So absolutely, transfer of technology to make sure that vaccines are manufactured around the globe and at the volumes that we need are really important important steps. And I think importantly, Africa is one of the continents that has the least manufacturing capabilities right now and has been lagging behind on vaccine use. And when you see those two things together, you go, hey, maybe it would be different if we had more manufacturing capabilities in Africa. And so I think you'll see the foundation supporting efforts to try and improve the manufacturing capacity on the African continent. which is going to take a sustained effort over time, building manufacturing capacity in any of the places. I know the ambassador from Vietnam is on, and that's a country that has invested in national vaccine manufacturing for a long time to be able to build its capabilities. And I think we'll be able to do the same thing in Africa if we take a long-term approach to it.
Thank you, Dr. Levin. Yes, we are joined by the ambassador of Vietnam, Mr. Hung, and the ambassador of Kenya in Israel, Mr. Parashina Kajiado, and also representatives from the Zambia, embassies of Zambia and Costa Rica. We can open the floor for discussion now. So by a raise of hand, if someone wants to ask a question, just raise your hand and I'll give you the right to speak. Zvi, yes, you wanted to mention something? Just unmute yourself.
Yeah, I cannot resist, but you asked before on lessons from the past and from the epidemic. One major lesson which applies to the issue of the IP, to the patent story, is the lesson that was learned in a hard way of making the antiretroviral available to all the developing countries. And I'm sure you are familiar with this story, but it was quite a serious battle between public opinion, governments, and the pharma, and it led to a very productive, constructive, I would say, arrangements by which generic drugs were allowed to be produced in the developing countries, providing that they would be supplied only to low-income countries. And at the same time, the rich countries, first and foremost, the United States with the PEPFAR story and then the Global Fund, helped fund these requirements and actually provided the cheap drugs to the wide populations of HIV carriers. Now, the lesson in our story is a very similar one in a way. I think the foundation has the clout and the ability to motivate or to initiate a discussion in which generic vaccines would be encouraged to be produced, say in Vietnam, say in other developing countries, provided that they would get patent or the IP from the major pharma that are producing it now. And that could make a change. That could make really a game changer.
Thank you very much, Professor Bentwich, for this point. With regards to the access to vaccinations, I wanted to ask you, maybe Dr. Adikiri, about the role of civil society organizations as opposed to governments. How can they play a role in making sure that the vaccines are equitably distributed to people?
One of the major constraints as to why people were hesitant, why in the first phase of vaccination was because there was there weren't much information about the AstraZeneca vaccine, and also I think there wasn't much transparency and communication around how we were rolling out the vaccines. I mean, like we rolled it out in a rush, and then so we received the vaccine, and then we started rolling out the vaccine. But there were healthcare workers, there were people. The people who were supposed to provide the vaccine were also not. They were not that trained about the vaccine. They were not quite informed about the vaccine. So I think as a government, the role of the government would be in being more transparent and communicating more about it and sending out more information about the vaccine. And also there could be we could engage the community who would actually reinforce the information about the vaccines information from the federal and state level to the community. So the more of the community engagement would also be is also one thing that the government can do. And I think the civil societies and the other partner, they can actually play a role in actually in liaising and collaborating or partnering to we are like we do not have an infrastructure where we can actually think about manufacturing the vaccine. We are not at that stage, and we have a constraint infrastructurally, and then also monetarily, and also also with the capacity. So we have all those constraints where we cannot think about manufacturing the vaccine by ourselves. So so we would rely much on getting the supplies, and because funding is one of the constraints. So maybe liaising with and collaborating with other countries and partners to bring in the vaccine so that we can vaccinate more people, because we've only been able to vaccinate only 7% of the population, and so I think those are the things that that can be done by the government and civil societies and organizations.
I have a question, if I can.
Please go ahead.
I would like to address that question both to Dr. Stella Bazire and Mr. Oren Levin. We discussed the vaccination, and there are different aspects. There is the logistic, manufacturing, distribution, and then there's also the discussion and the awareness, the communication, and this is the phase of implementation that is very important. We see different discussions, for example, even in Europe, where a lot of people are discussing which vaccine. And I think that the Dr. Stella Bazire mentioned that there is a lot of discussion between the vaccines, and there is a communication going on in the efficiency and the risk of certain vaccines. And I would like to ask Dr. Stella Bazire to know what's going on in Kenya in terms of the population, and how is it basically going in developing countries where maybe is the communication as viral as you have in Western nations, where people discuss article, the pandemic? How is the street language going on between the people, and what's the readiness for them to get vaccinated, the urge for the governments to take action to get vaccinated? I'm very curious about that aspect.
So right from the beginning, one of the things I want to laud the Kenyan government is that it really took up the issue around communication very well, in terms of using all forms of media to be able to alert the public around what COVID is, symptoms, just general information for the public to be able to actually make a decision around general information around prevention and control. Now that went, and I'm speaking from a civil society organization, and I know this has been an experience in a lot of the countries, until the problem where we had militarization of our public health issue. And when I talk about militarization of a public health issue, we saw, and this has been documented, the human rights violations around violence, around physical violence, arbitrary arrest of lots of the citizens. And that became very problematic, because now it became, we are in the middle of a pandemic, we have an issue, but then we are using force to be able to get people. So that's where I feel like we lost the plot, because the plot had already, the storyline had already started flowing in very well with the citizenry, and people were actually taking in ownership and even sharing this information until that happened. So it became like a pushback. And of course, civil society came up in arms, criticizing the government around the modus operandi on how it was implementing this. And that has been addressed and continues to be addressed. But I also feel like we have also not really done well. And I say we, cognizant of the fact that I am a global public health expert, is that even in our messaging, there is a way in which the packaging of the messaging cannot be one size fit all. That's also something else. And that's something that we also, I don't know about where you guys are, is that there's information for people in the rural areas, because also you have to be cognizant of around the social determinants of health around them. What is it that they can access? Can they access clean water? They can access clean water, so they can use that as one of the interventions. When you come to the urban areas, of course, we are more privileged. We have sanitizers and all that. Then we can be able to do. So I do not think the messaging really took into account.
I think I'm going to calibrate my question, because I think that we saw the major guidelines of the World Health Organization regarding COVID, and some of the messaging, and most of the messaging were implemented by every government and public health expert within the countries to indications of prevention, sanitation, wash, etc. My question is more based on the consumer effect, on the people, the prevention. I think that in many developing countries, and we've seen that through different Zoom, we organize, SID organized, that developing countries and the people not always have more difficulties to do isolation. They have difficulties in hands washing, sanitation. So the contamination, the virality is much more important, but also the messaging, the way they discuss the issue or the prevention between them, and later on with the prevention with vaccination as a prevention measure. Now, my question, and it is because right now I'm in a developed country, but working for the developing countries, is also to understand what is the street talk, what is not us as professional and global health expert or solution finders or problem solving, but what is the discussion happening on the ground with the people? Now, I hear that there's kind of clashes that happens between governments and civil society because of the restriction. It happens everywhere. It happens in Europe, in America, everywhere. But what is the discussion around the epidemic, the awareness, the people taking it seriously or not taking it seriously, and what are they pressurizing the government for vaccination? And we have more ambassadors for different countries here, and I'd be very happy for you also to comment, because while the global health experts are trying to create an impact and delivered solution, it's also very important to understand what kind of pressure have the governments with their societies in terms of addressing those pandemic.
I really don't, I'm trying to understand what you mean by the word street, but I'll tell you about communication. This is, I'm trying to understand what is on the streets, because
communities, the local communities,
they're different. The communities are not homogeneous. The communities are very heterogeneous, and that's why I was bringing out the conversation around the rural community is totally different from the urban community. The urban community, in terms of access to information, in terms of access to, in terms of literacy levels, also is a bit different. So those are multiple factors that would actually change how it is that information is. You go to the rural areas, for example, you will find that people don't wear masks. But in urban areas, people know that there's transmission through droplets, right? But in the urban areas, you'll find people walking with sanitizers because they know they have to sanitize the surfaces. In other areas where there are challenges, and this is a discussion around social determinants of health, you will not have such access to privilege. So the kind of information that you expect, or the kind of attitude at the grassroots levels, it cannot be homogeneous. It will also be dependent on many factors, such as, do they have access to clean water? One, do they have access to public health facilities? Two, do they have community health workers who are able to cascade information right from the ministry level all the way to rural homes, rather not rural homes, to household levels? That also will change how it is that there's perception. But I'll tell you for a fact that in terms of the whole country, there's a recognition that this disease is there, that this virus exists, and this virus is fatal. Because if you don't know somebody who's died, you know somebody who has been infected and somebody who has been sick. And that's one of the nexuses that is also helping us in terms of scaling up the public health information around prevention and control. People are saying, no, I know somebody. So because of that realization, initially it was, oh, there's somebody very far. Right now, because it's actually at our household level, it's at a community level, then there's a shift around the attitudes. There's a shift around behavior that even when there are certain constraints, you see an attempt to be able to do that which they can do with that which they have available to actually enhance their protection against C19.
Thank you very much, Dr. Stella. Unfortunately, we're almost coming to the end of this discussion.
Can I ask something?
Yes, but before that, Stella, Dr. Stella, thank you very much for raising the point that also applies to the development world in general, that there is no size fits all, and all solutions should be adapted to the current situations. Yes, Mr. Hagai Dror, it will be the last question, please.
Yes, hi, Hagai Dror, Managing Director of Healthcare Israel, is the international cooperation arm of the Ministry of Health. And I just want to ask maybe Mr. Levin or other participants, how and if you think that Israel can help in this global effort of vaccination, whether it's the government, a health organization, a private sector, and how can we contribute from our experience in the vaccination effort here in Israel to the developing countries?
So the simple answer to that question is yes, on all of those. I think there's a lot to be done. There's a lot to learn from the experience that Israel has had in early use of the vaccine, successful use of the vaccine. Obviously, not every aspect of Israel's system is analogous to the environments in which many of these other vaccine programs are going to roll out. But the attention to planning, the use of information as you went along to sort of adjust and accommodate so that you didn't try to one size fits all, but actually tried to kind of tweak as you learned along the way. Those are all things that I think both the government and the civil sector who've been involved in that experience can contribute. And in terms of private sector, obviously there's lots of different ways that private sector can contribute. We've heard a lot about vaccine supply being short, yes. But that's not the only thing that is a opportunity, if you will, in the vaccine rollout. One of the important opportunities is around information systems as well, and trying to improve operational information systems so that you can have a much closer management of data. I can tell you here in Seattle, the supply chain aspects of how we manage our vaccine rollout are just crazy making. It's basically once a week ordering based on paper submissions. I think they're now digital, but at the start of this process, it was a mix of paper and digital submissions. The state of the art in immunization records, I left mine upstairs, but the state of the art is a little piece of paper that we get issued. That's not the state of the art. There's much more that could be done on information systems that would help governments and individuals to both improve the operational efficiency of the vaccine rollout and include and involve individuals in shaping their own healthcare. And then lastly, to one of the points that I think we've just been talking about with Dr. Stella, there's a lot to be learned about tailoring messages and information for different communities, and importantly, about who delivers that message. One of the things that really sticks in my mind is a quote from a colleague of mine, Dr. Asti. He's the former head of the Kofi Annan Foundation and the International Federation for Red Cross Red Crescent. And what he said was, that stuck with me was, communities don't want to hear from someone who's parachuting in during the crisis. They trust the institutions who were there before the crisis are there during the crisis and will be with them after the crisis. And so a big part of this this evolution, I think, that we have to make in messaging is understanding who are those trusted institutions who were there before, who are there now, and who will be with the communities after the crisis, whom we can engage with in order to kind of help shape the demand for the vaccine as well. So I think that probably resonates with many of us who live in environments where there's a government saying one thing, and there are other institutions, social institutions, faith communities, et cetera, that are also trusted and sources of information. And so trying to kind of bring the lessons and observations from how to do that, I think is just one more way that I think the world can benefit from the experience and learning that Israel has had in this pandemic. Thanks.
Thank you very much,
Thank
Dr.
you.
Levin. I think with that we are coming to a closure of this discussion. We are already several minutes late, but given to the importance of this topic, I think it's worthwhile staying for a few more minutes. I would like to thank our wonderful speakers, Dr. Levin, Dr. Adikeri, Professor Bentwich, and Dr. Stella Busire. Thank you very much for joining us today from the US, Kenya, Nepal, and Israel. Stay tuned, follow us on Facebook for future events of Seed Israel. Good evening and good afternoon to everybody. Thank you so much.
Thank you.
Thank you.
And thank you, Ariel, for guiding us. Thank you. Thank you so much.
Thank you. Thank you.
Thank you so much, Dr. Levin.
Yeah, thank you so much. The present program. Thank you so much.
Thank
Very
you for
grateful.
joining us. Pleasure having you with us.
Pleasure. Thank you.